Good evening and welcome to the Brian Crombie Radio Hour on Saga 960 AM. I come to you every Monday through Friday at 6 o'clock on 960 AM. Today, Tuesday, April the 28th, is the day of mourning. And it's the day of mourning for people that have lost their lives in public service and particularly in healthcare settings. And so I thought it was very appropriate to bring on two people that know a lot about this issue. Michael Hurley is the president of the Ontario Council of Hospital Unions. It's part of the Canadian Public Service, the CUPE union. And Charlene Stewart is president of the Service Employees International Union Healthcare. Michael and Charlene, thank you so much for joining me today.
Thank you.
That's a pleasure. Thank you.
So, you know, COVID-19 has had a devastating impact on people. Worldwide, we have, I think, close to 1 million people infected. We have one of the largest infections since 1919 in history, and certainly one of the largest death rates. It's impacted our lives, both from a home life standpoint, a business life standpoint, a community life standpoint, but it's impacted healthcare workers more than anything else, and long-term care healthcare workers more than anyone else. Both of you represent those areas. Tuesday is the day of mourning that was established, I guess, a decade or two ago to honor people that lost their lives. I think healthcare workers at frontline workers have been really put in almost an untenable situation in this last month, 6 weeks, etc. Michael, maybe I could start with you. What do you think about when you think about a day of mourning, a day of appreciation for our frontline healthcare workers?
Well, I think it's really important to memorialize the people who have given their health or their lives, not just in healthcare, of course, but in many occupations. I would really hope, particularly thinking now of healthcare workers, that this day of mourning we could dedicate to trying to make sure that we're doing everything that we can to keep the people who are working to deliver health care and long-term care and the home care and in hospitals as safe as we possibly can, and the people that they care for as safe as we possibly can, and that would be an excellent focus for us because we sure have a lot of work to do.
Charlene, what about you? What do you think about on this day of mourning?
Yeah, I mean, April the 28th always is a day that we stop and recognize the issues at work that, again, nobody should leave their home in the morning to go to work and not return to their families at the end of the day. So we recognize and honor those who have lost their life at work, but we also lobby very strong on April the 28th to ensure that we continue to prevent those things from happening. And yeah, the COVID pandemic has really shone a light on the sacrifices that workers are placed in front of them. No matter what job they do, they're in danger. And who would have ever thought that a pandemic like this would affect so many lives? So this April 28th, I am reminded, you know, personally, because of the member that we lost, that we have to do much, much, much better to make sure that people do not die at work.
Charlene, maybe you could tell me, who are the frontline workers that you represent?
Michael and I, who we represent similar members, hospital workers and senior care workers and long-term care, retirement homes, nursing homes, home care, paramedics, some community service workers, and a little bit of RNs. But yeah, almost everybody but doctors.
And that's all in Ontario?
Across Canada. Yeah.
Across Canada. And Michael, what about you? Who do you represent? What frontline workers do you represent, sir?
Yeah, no, there's almost complete overlap with the people that Charlene represents. I mean, some paramedics, I think we represent both our unions, some of those, and technologists, but you know, mostly we're people who are on the front lines of delivering care, or the people who are supporting them to do that in various capacities like cleaning and maintenance and other areas.
So probably the biggest issue that we've heard about over and over and over again is, do our frontline workers have the appropriate equipment? What do you think? Are we doing an adequate job, a good job in Ontario and in Canada in supplying our frontline workers with adequate equipment?
Both of us, frowns on our faces. Absolutely not. No. We have seen outrageous negligence, uh, I would say missteps. Just it's been very reckless and careless. It has not been transparent. Actually, I would say they did more work trying to keep the truth away from us than they did working with us to ensure that the proper infection control and protective personal equipment was in place.
Really outrageous and negligent. Michael, do you agree?
Oh, absolutely. I mean, for example, we had a huge stockpile of protective equipment that was built up on the recommendation of the Campbell Commission after the healthcare workers died during SARS. And all that equipment was allowed to expire, 55 million protective masks, and not replaced. And then when the province realized a new pandemic was coming, they couldn't order material because of all the competition on the global markets. They watered down their safety advice to healthcare workers to make it conform to the equipment that was on hand. And that's probably the primary reason why you've got over 2,000 Ontario healthcare workers sick today with COVID and at least 2 dead that we know of. So,
Hold it. 2,000 healthcare workers currently infected with COVID-19.
Yeah.
In Ontario alone.
Ontario government stats, and we would probably suspect that because we're not testing, that really underestimates the numbers. Yeah.
So, this is not information that you get from our nightly news. How come this information, Charlene, is not being publicized?
Well, because it's bad news. And the stats that Michael cited are probably low too, because they are not being transparent with the unions that represent these workers, but also even public health. You can't get the same number if you call 3 different places. So I would say that those numbers are even understated.
So, I don't want to play the blame game, but let's play the blame game here for a second. So you're saying that we allowed equipment to go expired. We had a Campbell Commission. You mentioned this was after what, SARS? And it was determined that we needed a certain supply of protective equipment to be just held in reserve. And what happened? We just forgot about it. We didn't monitor it. We cut back. What happened? Michael?
Okay. Well, I mean, I think people forgot about SARS. They forgot the lessons that were to be learned from that experience. It wasn't a priority. I mean, we had the same experience to a much smaller extent during the Ebola outbreak, if you recall. It became clear that we didn't have the equipment on hand. Steps were made at that time to deal with the immediate crisis, and thankfully that virulent virus didn't spread. But you've got a bunch of factors conspiring here. You've got a decision to centralize the supply chain, and you've got the health and safety of workers not being a priority. These are important factors in what has gone wrong here, I think. And you've got, as Charlene said, a lack of consultation with unions, perhaps an ideological objection to dealing with unions, unfortunately, and so dialogue doesn't happen. So a bunch of things conspire to make this crisis worse than it should be.
April 28th is a day of mourning to commemorate particularly frontline workers, healthcare workers that have died in action in their daily work on our behalf. And so we've got a show tonight all about healthcare workers, frontline workers, and what's going on with them in regards to COVID-19. We're going to take a break for traffic and messages. Stay right with us.
This one seemed to be like an hour long.
Well, welcome back, everyone, to the Brian Crombie Radio Hour on Saga 960. Today is the day of mourning, to commemorate frontline workers, healthcare workers that have given of themselves for our benefit. And I think this was established a decade or two ago. And every year we commemorate our frontline workers. And I thought, given what's happened with COVID-19, it would be completely appropriate to have Michael Hurley, the president of the Ontario Council of Hospital Unions, part of the Canadian Public Service, with us, as well as Charlene Stewart, the president of the Service Employees International Union Healthcare, to talk about COVID-19, to talk about frontline healthcare workers, and to talk about what they do and what we can do to ensure they are safer on their job. When I think about our Canadian socialized healthcare system, we often get fairly high praise, and COVID-19 has probably shown some cracks. I've been interested to compare, the cracks that we've shown in Canada versus the cracks that have been exposed every night on CNN or Fox or whatever in the United States. And frankly, I feel good that we have a lot less cracks than it would appear the United States has. But many of those cracks are sort of been blamed on not being prepared, not having the right supplies in store, not learning from SARS, not learning from Ebola, not learning from the past. You are both responsible for fairly sizable unions. You interact with government and healthcare and public healthcare on a fairly regular basis. What went wrong? Are they not listening to you? Are they not listening to the scientists? Are they just cutting corners? Why do we have these problems? Charlene?
Yeah, I would say the problem started long before the virus hit the world, particularly in senior care settings like nursing homes, retirement homes, and home care. A lot right across North America, a lot of those homes are managed by for-profit corporations. A lot of the same names you'll see right across the US and Canada. And again, the staffing levels and the shortage of personal support workers without a pandemic was already in a critical state. So when the virus hit our country, and particularly Ontario, we raised the flag with this government saying, what are you going to do to ensure there's enough workers to deal with what was predictable? For the Minister of Long-Term Care to say that she had no idea about the staff shortages or that it would affect a population of over 80, that was already happening in other areas around the world. So this was not a surprise. We raised the flag, we asked the questions, and the reason why they did not place the order to have workers work in one place is because they knew they didn't have enough of them to go around all the homes, that if they ordered one workplace, that would put another long-term care home in a disadvantage because they would not be able to staff up, which unfortunately, 4 weeks later, we saw like a horrific crisis happen. It started off in participation place where there was 50% of the workers were off either because they chose one job to work in or else they were infected or in isolation. That was absolutely predictable at the very beginning of this.
Now, when you say the beginning of this and that you warned the provincial authorities, are we talking February or early March or mid-March?
Early March.
Early March
when we were in conversations, yeah.
Because, as we know, we had cases late December, early January in China, but we really didn't become focused on this in North America, I think, until February. Really, it wasn't until some of the athletic leagues started closing things down, it would appear to me, in sort of that second week of March, that really provincial authorities started taking things seriously.
Well, they were much too relaxed. There's no question. When you think about decisions that weren't made, for example, to step up the purchasing of protective equipment, to block visits into nursing homes and long-term care facilities to protect the people inside, to consolidate our ability to be able to test people for coronavirus. Once it became clear that we didn't have the ability to get the equipment we needed, we could have ordered Ontario Industry to make the equipment. I mean, there's a number of areas where we certainly could have done so much better. And on the human resource issues that Charlene was talking about, it's been a bit of a bungle, really. Managing the workforce in healthcare, and this despite the fact that the Campbell Commission, which looked at the SARS disaster, it made a series of recommendations about, for example, the casualization of employment in healthcare. It recommended that be remedied, and here we are 18 years later, and in fact, it's gotten much worse.
What do you mean the casualization? Please explain that.
I'm sorry. It's the percentage of the workforce which is part-time. And Justice Campbell recommended that, particularly for the people involved in providing direct care, that a 70% full-time complement was ideal, recommended. And in fact, we're under 50% of the workforce being part-time. So when you try to stop people from moving from facility to facility because they could carry the virus, even if they were, even if that was unintentionally, that creates a whole host of problems, which Charlene was mentioning.
And the casualization is what, a cost-cutting measure because casual workers are cheaper than full-time workers?
Exactly. Yeah. And like I mentioned, a lot of these nursing homes and retirement homes are run by multinational corporations who, Chartwell, for example, is worth $2 billion annually. And yet we saw a year ago to the day where the government imposed the wage cap on these workers. So they're already working part-time jobs. They're low paid. The majority of them, if you get a full-time job in these homes, you might make $35,000 a year. And you have to seam a bunch of jobs together to get that. And then of course, if you're holding more than one job, then even to get called in for full-time at a home, you can't do it because you're committed to your other part-time job. So that, the part-time work, the low wages, no benefits, and the wage cap, and then you add on to the fact that the government cut the inspectors for these homes as well, when we were already in
Hold it. You're saying that the government cut inspectors of seniors' homes? When was this?
That was last year. That was after the Ford government got elected. They did a lot of cuts. They took away sick days, paid sick days in some of these areas as well. So all of this was like the perfect storm to have us land where we are today. All of it could have been prevented.
Prevented by what? More full-time people, by better stockpiles, by more inspections. What else, Charlene?
Well, and being prepared. I mean, we said we were meeting with them in early March, and we absolutely had the SARS recommendation right in front of us. We cited it, and it was like, honestly, it went through one ear and out the other. They weren't transparent with us. We were hearing off the front lines that we did not have enough personal protective equipment. Yet every time we questioned the government, they said, we have an adequate supply. We have an adequate supply. And like Michael said, had they been transparent and open, we would have worked together with them. We could have had these companies be transitioning the workplaces into making PPE. Hundreds of deaths and thousands of infections later, they start to put an iron ring around a home or the sector that had nothing but a plastic mesh with lots of holes in it. A lot of this, I will stand for a long time saying it could have been avoided. Much of it could have been.
Well, that's a very sobering assessment of what happened. And frankly, I pride myself on being a news junkie, and I've been watching a lot of the different press conferences, and this is something that I haven't heard a lot of. So this is concerning.
Great.
So a year ago, I think, in addition to some of the cuts that you mentioned, President, sorry for that Freudian slip, Premier Ford centralized all of the healthcare agencies into one provincial body. Was that a good decision? And what was your two unions' position on that? Michael?
Well, we were opposed. I mean, from our perspective, there never was a need for an additional layer of bureaucracy in the Ontario healthcare system. What was needed was more staffing. In particular, we have the lowest level of staffing in long-term care, hospitals, and home care of any of the provinces, and indeed of any country with a developed economy in the Western world. That's where our healthcare system is failing to meet the mark. And so you've got this sort of theoretical idea that if we simply take charge and consolidate on some sort of East German model, that you can make things more efficient. But actually, and you can see it roll out in the N95 and surgical masks and the face plates and the ventilators and the testing kits that never arrive, right? They promised the 65 million the federal government has promised, the 6 million the Ontario government, they never actually arrive. They're like always on the horizon, these shipments, and you've got this newfound bureaucracy which doesn't have the same savvy. It doesn't have the expertise that existed previously. It's taken all that over. It thought it could do it better, and it's actually quite inefficient. So like now we just don't have to deal with the Ministry of Health. We have Ontario Health, and Ontario Health is now responsible for the hospitals who have their own association, right? I mean, navigating this bureaucracy alone, requires like its own course. But in terms of helping on the front line, helping for improvements to the quality of life experience of long-term care residents or cancer patients, or that doesn't get helped here by this kind of change.
Michael, you used the analogy an East German model. Is it really an East German model, or are you just using that from a descriptive standpoint?
No, I was being sarcastic. It's a central planning model, right? The state creates this consolidation of purchasing or whatever on the theory that it must be more efficient, right? Practically speaking, it's inefficient.
Charlene, the heartbreaking realities of seniors' homes, and not just in Ontario, but frankly worldwide almost, really suggests that we've got a failed model or something. What do you think the answer is? Is there a different type of regulation we need, or something different? Like it's incredible that we can have these institutions where we send our loved ones and pay lots of money in a lot of cases, whether it's through taxation or whether it's private and direct, hoping they're going to be cared for in their final years. And then to have this unbelievable experience that we've been hearing about in Ontario and in New York and in Washington and in Europe. What do we need to do?
All of this falls directly on the government. No matter what government is in place, it starts with them. These corporations come into our countries, they come into our provinces, they make tons of money on this business. The governments have got to keep them accountable. There has to be stronger regulations. Retirement homes have no regulations whatsoever, and as you said, they charge $10,000 a month to stay in these homes, and the homes are rationing meal allowances per day to be about $7 to $10. There's got to be oversight. The government could have been taking over the last year, holding corporations accountable that if you're making profits in our province, you have to put it back into the front line. I mean, even now in the last week, everyone was donating PPE, Bell Canada, companies and corporations are changing and adapting to make these. Where were the names like Sienna, Chartwell, Extendicare? None of those multi-billion-dollar corporations donated one mask to the front line in either one of our countries. And if I'm asking the questions, why isn't the government asking these types of questions of those people? You make profits in our province, then you've got to be putting in a certain percentage, or there has to be a cap on the profits that you're able to make off of human lives, whether it's the residents in these homes or the frontline workers. So it starts with the government.
I did have an owner of some seniors homes, or an investor in some seniors homes, say that there wasn't a problem in the Class A, Class B homes. It was in the Class C homes. I wasn't even sure that there was such a categorization of homes. Do you agree with that assessment?
No, this virus has not been selective at all. In some of the Class C homes, maybe you've still got the 4-person wards, where we argued right from the beginning too that they had to ensure that there was cohorting. That would have also helped the situation early, that if there was an infected residence, that you assign a specific deliberate staffing team to take care of them. But no, there was infected residents staying in a 4-ward room with a curtain between them with non-infected residents. So that is maybe what they mean by some of the classes that could have been in a little bit more precarious position. But it should have been, let's find answers, let's not make excuses over all of this.
Last week, the Premier brought in the Army. Was that the right decision?
Yeah, I mean, all hands on deck at this point is the right decision. But again, did it have to get to that? I don't think so. And what exactly are they doing in there? I haven't been able to find any answers as to what they're doing. We're hearing that the administrative managers are not in the workplaces. I mean, they don't want to be in there. There's an infection in there. So if the Army's in there, who's directing them? Are they directing and managing the homes? We can't get those answers out of there. But I know one thing, they're not enough. I heard on the weekend that we're still short 3,000 frontline staff in these homes as of Friday. So that's
We're
a
short
lot.
in Ontario, 3,000 frontline staff. Is that correct? 3,000 in Ontario alone?
Yes.
That's unbelievable. We're talking with two individuals from different unions that represent our frontline workers in long-term care and in hospitals this evening on the day of mourning for healthcare frontline workers. We're going to take a break for traffic and messages. I think, frankly, we should take a moment of silence. This is a very disheartening conversation, but let's hear more about it. Stay with us, and we're going to come back in just a minute. Well, welcome back to the Brian Crombie Radio Hour on Saga 960 AM. Today, Tuesday, April the 28th, is the day of mourning. And maybe I'll ask one of my guests to explain exactly what the day of mourning is about and why it was instituted and when it was instituted. Because I think it is something that is to recognize frontline healthcare workers that have lost their lives in their jobs, taking care of us. Today, I'm joined by Michael Hurley. He's the president of the Ontario Council of Hospital Unions, part of the Canadian Public Service Union, and also I'm joined by Charlene Stewart, who's the president of the Service Employees International Union Healthcare. Michael, I think you're primarily hospital workers, and Charlene, I think you're primarily long-term care workers. Is that correct?
Yep. Yes, yeah, we represent a little bit more than CUPE. CUPE represents more hospitals, but we're very similar.
Okay. Michael, we've chatted a lot in the first section about the impact on long-term care primarily. What about hospitals? What's the situation in hospitals? Is it as bad as it is in long-term care? My sense is that, they set up these tents or places at the front of hospitals to sort of triage and deal with people that might have the infection or not have the infection. And so that might be keeping the infection out of the hospitals a little bit more than it otherwise would. I've gone by and they seem to have a reasonable amount of protective gear at those little triage tents. But what's the overall situation like?
Well, the hospitals have discharged a lot of patients that they would call alternate level of care patients, who would often be older patients, and they would often have complex medical conditions and be waiting for placement into a facility. And because of those discharges, the hospitals are operating at about 67% capacity today. So they do have some ability to take people. And one of the questions that we would ask, going back to long-term care briefly, is why it is that so few long-term care residents who get COVID are actually transported to hospital. And we're concerned that what we may be seeing is a form of rationing in terms of keeping them in the home, even though they have a virus which is highly contagious and which is spreading like wildfire to the other people who are around them. I think it's a question we should perhaps return to. For the people who work in the hospitals, though, the situation is, it's a little bit different from the situation in long-term care, because the staffing levels are a little bit better, and there is more access to the protective equipment. But I can tell you that, people are unable to get the kind of equipment that we believe they would need to keep themselves safe. I'll give you an example of a pregnant woman who's a cleaner in a hospital in Southern Ontario, who's asked to clean an ICU room with a COVID patient in it, and asks for the respirator that you use in those situations, and is told no, even though pregnancy is a condition that really goes badly with COVID if you get it. So those fights for equipment are going on all the time. And, our health and safety committees, which are supposed to be quite integral to making sure that people are kept safe, are very much kept out of planning, risk assessment, inspections. So, there are significant problems in the hospital.
Michael, have we lost you? Are you there?
Yeah.
Oh, you're back. Sorry.
Yeah, I just stopped talking, Brian.
You talk about rationing, that you fear that people with COVID-19 in long-term healthcare facilities aren't being transported to hospitals. I haven't heard that before. So what do you think is happening? You actually think that that there's some structure within our public health system, our healthcare system, that's saying leave them in the long-term care facility to pass away?
Well, before COVID, we had our hospitals operating at like 110% capacity, right? We had no flexibility. We cut 20,000 beds over 20 years. And so, at the long-term care level, decisions were made before COVID to restrict the transfer of long-term care residents to hospital, even if they were acutely ill. And so now with COVID, even though there's capacity that's opened up in the system, you will find, if you look at some of these examples, like Almont is one, close to Ottawa. 15 people, I think, died in a long-term care facility. I talked to a reporter who told me that, they could find no one who had been transported to hospital. I think it's true in Bobcaygeon. So as you go through them, if you actually look at it, there's an issue underlying it, and it's one that should really disturb people.
So you said that we cut 20,000 beds out of our hospital system in the last, how long?
20 years.
Last 20 years, we've cut 20,000 beds. And that's obviously based on cost cutting. Our population has increased, so the per capita number of hospital beds have gone down fairly dramatically. Do you, by any chance, know what that number would be and how it would compare to different provinces or to the United States?
We've got the lowest level of acute care beds to population of any country with a developed economy. There are a couple who are underneath us, but like Turkey has more beds than we do. Belgium has more beds. Britain, the U.S., they all had more beds to population, and this has an impact on access, obviously, right?
We have the lowest number of beds per capita for developed countries, is what you're saying. And so that's not a provincial impact, that's a federal impact.
Well, I mean, some provinces have better staffing levels, but the federal government's withdrawal in terms of the reductions it's made to health transfers to the provinces is very much a factor here, probably. Yeah.
That's a shocking statistic, again, one that I hadn't heard. So we've got a low number of beds per capita. We've taken 20,000 beds out of the system. That 20,000 is an Ontario number or a federal number? Ontario. Taken 20,000 beds out of use in Ontario. And you said we've gone from a hospital occupancy from 110% down to 80%, you said?
67 today.
67%. So we've obviously opened up a fair amount of space by canceling elective surgeries and other surgeries, but there's got to be a lot of people that we're expecting to have things done that aren't getting them done, chemotherapy and other things. Like, are we setting ourselves up for a big bolus of needed treatments for other disease states as soon as this is over, if it's ever over?
Well, we are, because this stuff just backs up, right? And of course, like I'm waiting for cataract surgery on one eye, and that's no problem. But if I were waiting for cancer care, I would be greatly distressed, and it would certainly have an impact, right?
Well, to go from 110% pre-COVID down to 67%, there's a lot of stuff that would have been occurring in the hospitals that we've either canceled or not allowed to come in. So I was traveling in the United States. I came back to Canada. I was told to self-isolate. I self-isolated. I had a bunch of symptoms, and I had 3 different physicians tell me, don't go get tested, because if you go to a hospital, get tested, you've got a bigger chance of actually catching something. And given that your symptoms are mild, you're just going to be told to go home and take care of yourself anyway. So there's got to be a whole bunch of people like me that aren't going to the hospital, aren't getting tested, and I'm not sure what the implication of it is, but I think there's a lot more COVID-19 out in the community than we realize.
Yeah, 100%. There's not enough testing being done, and the emergency rooms are empty at the hospitals. But then again, I go back to the long-term care situation when I said about cohorting. Why not use some of those empty wards as well on the hospitals to put some of these, maybe the healthier, non-infected seniors in those homes into those hospitals? Again, there was more excuses not to do it than a willingness to figure out how do we protect these people.
Now, in 1919, there was a second wave in the fall, and almost, maybe similar situation to what's happening now. After the first wave, there was a lot of political pressure and economic pressure to reopen, and in a lot of places, cities and provinces and states and countries reopened more quickly than they maybe should have. And then the second wave was actually more lethal than the first wave. Do you think that's a chance here? And if so, what do you think we need to be doing to plan for it and get ready for it?
Yeah, sadly enough, absolutely it's a possibility. I mean, we've got things to celebrate, that the breakouts in the hospitals and the admissions isn't as high as it could have been. So thank God for that. But then you take a look at, again, the seniors community, how it's just, extremely sad what's happening in there. I have real concerns about how fast we come out of this and how we manage this. I mean, the economy obviously is extremely important. So is people are going a little bit, cabin feverish being inside, but we all need to be so careful. And I'm worried that government might be in, too much of a hurry to answer some of the pressure that's coming on them. So we need to be very careful.
So, if you as a union leader and as a healthcare practitioner knew that there was going to be another wave in 3 months, in October, 4 months, what should we be doing now?
Well, right now I'm calling on all of the long-term care employers and the Minister of Long-Term Care to work with us right now to get prepared for another outbreak that could affect the rest of the population in the seniors' home. The hospitals, we need to get prepared for that as well. How we readmit people, absolutely, we've got to get back to taking care of cancer patients and biopsies and radiation and chemo, 100%. They need to be working with all of us to do that transition. Be prepared.
Is there something we can do over the summer in long-term care facilities to be better prepared for? And cold and flu come back naturally in the fall and winter anyway. So it makes logical sense that it could dissipate for a while in the summertime and come back even more ferociously. Are there things that we can be doing in long-term care right now?
Starting off with, let's wipe the dust off of the SARS report and take a look at that and match it to what we did wrong this time. It's glaring. It's not hard to figure out. You just have to make sure that you avoid it and we're prepared. Hopefully we'll have stockpiles this time of PPEs. Don't stop making those over the summer. We need all of that. And unfortunately, the nursing home owners and corporations have not reached out to us to have those conversations, but the government has committed, as well as other experts, to all work together to ensure that we're ready for the next wave.
Michael, what about you? What do you think we need to be doing if there is a risk of a second wave in the fall?
Well, I mean, one area where we're woeful is testing. We test, I think, about 10,500 people a day in Ontario on a population of 14 million. So we really have, I think we've tested 250,000 people. So we really don't have a handle on how widespread the virus is. And in particular, your vulnerable populations who are living in long-term care and in hospital and who are being cared for in the home, and all of the staff who work with them need to be tested ruthlessly. And other countries that are much more successful than we are at dealing with coronavirus do it by testing aggressively, and aggressively doesn't look like 1/100% or something. It aggressively is a significant test. You identify people who have it, you remove them from the collective, you take care of them in specialized settings like hospital, you provide them with an additional a higher level of care. So testing is one thing. And we believe, as you believe, Brian, that, people will let their guard down, unfortunately, and, we'll be walloped by a wave. And we don't have the equipment now to be able to provide care safely. It isn't just a concern, a selfish concern. The people who aren't given the equipment can get the virus. They can They can transmit it when they're asymptomatic to their coworkers, but more importantly, to people who are very vulnerable in terms of their immune systems. And this is something that needs some urgent work. And so it was so disappointing that the federal government, on the one hand, announced reopening the General Motors plant in Oshawa to make masks, but then didn't make the N95 masks they're making in Michigan, because it's the N95 mask, not the surgical mask, that we need when we're dealing with in close contact with coronavirus patients. Because as we both mentioned, the healthcare workforce is not that big, and it's already got a significant attrition rate by virtue of people falling ill. Already, like over the last week, the number of cases of healthcare workers has climbed from like 9% of all cases to almost 14% of all cases. Like the number of healthcare workers falling ill is significant. And in these professions, you can't replace people on a dime. So in order to be able to meet the healthcare challenges of the months ahead, we have to pay a lot of attention to the safety protocols. So really like to see that. And, personally, there are two epidemics, as you know. There's the one going on in the community, but there's the terrible one going on in long-term care, and taking special measures to identify, segregate, and care for the people who have COVID, and protecting the people who don't in those environments will be huge in terms of reducing the death toll that's going to come out of this pandemic in our province.
I'm talking to Charlene Stewart and Michael Hurley on the day of mourning. We're going to take a break for traffic and messages and come back in just a minute. Stay with us. Welcome back to the Brian Crombie Radio Hour on Saga 960. Today, Tuesday, April the 28th, is the day of mourning, which is a day to mourn healthcare workers. I'm joined by Michael Hurley of QP, hospital worker and long-term care worker union, and Charlene Stewart of the, where is it here? The president of the Service Employees International Union of Healthcare. Charlene, maybe you could tell me what is the day of mourning? When was it instituted and why?
Well, April 28th is the National Day of Mourning, where we have ceremonies throughout the country. In Ontario, we will have many, or had many, at 11 o'clock, where we lay wreaths and names are cited off of workers who have died while at work. This year, obviously, we won't be doing that. A lot of virtual events will be happening throughout the province. But it's a day where, yes, first of all, we mourn those who lost their lives performing work. And this year, it's a special added recognition and I hope awareness that there's a real risk of losing a lot more frontline staff because of the COVID pandemic. And SEIU will be mourning the loss of a personal support worker who died doing her job, and her family, her husband, and her 2 children are also infected. So the day of mourning is recognizing workers who have died on the job, but also a moment and a time to lobby hard that we do better than this. No one should get up in the morning, go to work, and not return home to their families.
Michael, do you want to add anything about the day of mourning?
No, I mean, just that unfortunately it's an event that's built on the bones of thousands and thousands of workers, miners, and others who have perished, and often perished because not enough attention was paid to their safety and well-being. So it's a day of mourning, but it's also a day of commitment to try to do better. And we certainly, in the midst of this crisis, want to do better for the people that Charlene and I represent. Absolutely, we do.
Michael, do you have a message? I think, frankly, I'd love it if you'd give me a message for both healthcare workers and the population in general, if you could today.
Well, I think we should be, I think this is a time for us to be active. This is a time for us to be outspoken. This is a time for us to draw attention to the failings that we see, in our case, in terms of the protections that we see in place for workers, but as importantly, the protections that we see in place for the safety and well-being of the people that we try to care for every day. So, I mean, this is a time for all of us to be activists, all of us to stand up and fight for the well-being of others.
Charlene, how about yourself? Do you have a message for either healthcare workers and or the population in general that might be listening to our show today?
Yeah, I mean, what I would ask people to do tomorrow at 11 o'clock, to take time today and just, take a moment of silence, recognize the heroes that we are seeing today on an hourly basis. I want to send a message to all the frontline workers who are out there, either ensuring that we're fed, that we're taken care of, that we will all be pausing and recognizing and honoring you tomorrow.
Well, thank you very much, both of you, for joining me today. I'd like to thank Michael Hurley, who is with CUPE, President of the Ontario Council of Hospital Unions, which is part of CUPE, and Charlene Stewart, who's the President of the Service Employees International Union Healthcare. And Michael is joining me from Ottawa, and Charlene, I think you're joining me from, what'd you say, some small town north of Toronto?
From Innisfil.
Innisfil, on the way to Barrie. Both of you been involved in the healthcare sector, long-term healthcare sector for a long period of time, leading unions, dealing with some of the most important people in this healthcare crisis, in this pandemic right now. And so thank you very much for your efforts, and thank you on behalf of all of the citizens of Ontario for all the efforts of all of your union members and what they're doing to make our community far safer for all of us. And I think I do agree with a lot of the sentiments that you've made in regards to we've got to be active, we've got to be supportive, we've got to stay at home, we've got to social isolate. Actually, no, I don't think we need to socially isolate. We need to physically isolate, physically distance, but socially we need to reach out and touch people virtually. And I think we need to recognize this day of mourning. Anyway, thank you both for joining me tonight. I really appreciate it. We're going to take a break, last break for traffic and messages. I'm going to come back with a few of my concluding comments. Stay with us.
Thank you.
Well, welcome back to the Brian Crombie Radio Hour. So today, Tuesday, April the 28th, is the day of mourning. We've had two individuals from our different unions representing both the long-term care workers and healthcare workers joining us tonight. I thought they did an excellent job in telling us about, frankly, some of the realities and a lot of facts that I worry we don't hear about. And one of the positives about Canada is that we're not as partisan as the United States, but one of the negatives of Canada maybe is because of that lack of partisanship, we don't necessarily have people like Michael and Charlene that are out there on a newscast on a day in and day out basis telling us about the realities. And just to remind you of some of the things we talked about, Michael said that there were 20,000 less beds in Ontario over 20 years. He mentioned that we have the lowest per capita number of beds in the hospital system of any developed country. And that we've gone from an occupancy in our hospital system of 110% to 67%, which means that we've freed up room for all of the people that may get COVID-19. But we've also, what we've done is we've limited maybe long-term healthcare workers, long-term healthcare residents that might be COVID-19 infectious, needing hospital service from coming into the hospitals, and frankly, a lot of other people that have got cancer, chemotherapy treatments, whatever it is that's wrong with them, from not going to the hospitals. And so we are going to be leading up to a bigger healthcare problem in the coming months. And I think we need to be concerned about a second wave and being prepared for the second wave. And Charlene certainly educated us in a bunch of the healthcare equipment that we have not stockpiled, that we allowed to expire, that we haven't been ordering, that we didn't instruct different companies in Canada to start producing, etc. So bottom line, we've got a problem and we've got to deal with it. And in the break, Michael told me an interesting, frankly, it's a scary statistic, that the death rate in long-term healthcare facilities, long-term care facilities that are privately owned is twice what the death rate is in publicly owned, which must mean something about the profit motive, cost cutting, less staff, something. I don't know what it means, but it means something when you've got a death rate that can be that dramatically different. Anyway, today is the day of mourning. We need to recognize the people who have put their lives on the line for us day in and day out at hospitals and long-term care and a lot of other places. And we need to support them. And we need to support them with our support. And clearly one of those areas is that we need more funding, because I do think we're going to have a second wave. I worry about that. And the only way for us to protect us for that second wave is to get more money into hospitals, into long-term care. So thank you very much for listening to me tonight. Have a great evening. And Michael and Charlene, thank you so much for joining us. I really appreciate your time on this day of mourning. Thank you.
My pleasure. Thank you.
Thank you, Brian.